very much for this compliment, ladies and gentlemen, dear Chairman. We will give a lecture today about the surgical management of aneurysmal diseases in Shifa Hospital. This is a 3-year experience presented by me and Dr. Lsmail Eljadba, the head of the vascular department in Shifa Hospital. It's actually, we have no fees for this lecture or the declaration of conflict is absent. Objective, it's a series. We will count about 20 cases of aneurysms, different aneurysms, of course, with some hotspots at some difficult cases and rare cases. Most of the cases were male patients. The age distribution, as we can see, we have noticed that 2 cases of suprarenal aortic aneurysm were young, Marfan syndromes, and the infrarenal were too old. And the carotid aneurysm also is an old man. However, the visceral aneurysm, like the splenic and renal, are young or middle-aged ladies, and the SFA and popliteal and the brachial are mostly young adults. We have 1 case of ruptured carotid aneurysm, 1 ruptured splenic aneurysm, 2 brachial, 3 common femoral, 2 popliteal, 1 renal, 2 SFA, 1 external iliac, 4 ruptured aortic aneurysm, and 3 aneurysmal AV fistula. Most of the cases were 2 aneurysms, and we will see that most of the cases are ruptured. We have 2 mortality cases, the suprarenal aortic aneurysm of exsanguination. We have done 3 aortoiliac bifurcated dacron graft, and 1 aortic tube dacron graft, and 8 interposition vein graft, and we have a 1 novel transobturator iliopopliteal bypass in 1 case, which we will discuss now, and ligation in most of the cases with splenectomy in 1 case, and 1 with the carotid aneurysm. We will see, we conserved on 2 cases which were medically, they have their medical indication like Behçet syndrome, and another incidental finding, we will see it later. We will look to the interesting cases immediately because of the time. Ruptured aortic aneurysm, this is the first case. He's a 53-year-old male, came to the emergency department complaining of left flank pain. We found after ultrasound and urgent CT that the patient has a huge retroperitoneal hematoma. And the thing which is noticed here, that the patient has also a right common iliac aneurysm. We put the patient in the OR and we did an aorto bi-iliac graft, and we landed on the external iliac here and to the common iliac here and to the external iliac here, and we ligated the internal iliac. As you can see, the aneurysms, the GAZ score, which is the Glasgow aneurysm score for this patient, is 68, which gives a mortality rate of 28. And this is the image of the sac, and here at the site of rupture, and this is landing of the aortobi-iliac graft, and with the telescopic technique, putting the graft inside the aneurysm, inside the neck, without showing any stitches. The second case, she's a 76-year-old female. She's diabetic, hypertensive, and chronic AF, and came with the same picture, and she has a huge aneurysm of 15 centimeter. And the nice thing, or the difficult thing in this case, that the lady has a dissection in the sac, in the aneurysm, and this dissection flap is continuous to the right side, which is the right common iliac. So we have a huge aneurysm with a tortuous neck, as we can see, a huge angulation, which is called a hostile neck, and it's difficult or sometimes contraindicated to put an EVAR in this neck. What we have done is, through an open approach, we did, through a wonderful teamwork of nice surgeons and nice anesthetists and nice blood bankers and the radiologists. The teamwork was very nice in this case, actually, especially also with the nurses. And we did, we opened the sac, and we did the same like the previous case. The nice thing is that we opened the dissection as well, the dissection flap. We inserted the aortobi-iliac bifurcated graft as well inside the sac, and we can see the site of the rupture of the aneurysm with the huge redundant sac here, and we can see the angulation of the aneurysm as well. The angulation is evident in this case, and after 6 months of surgery, the angulation is started to go away, and the nice landing and the arterial system of both arteries, of course, because if we remove the dissection, or we opened it one lumen, we ligated the internal iliac and we landed with the graft on the external iliac. This is the final images afterwards. So we will not talk about studies. The mortality cases are 2 suprarenal aneurysm. They died of exsanguination. One of them died intraoperatively after a massive rupture. The patient came extremely very shocked, and we did not catch him. And we had Mr. John Wolf in the second case, tried also to assist in this surgery, but the patient, he was visiting Gaza at that time, and the patient unfortunately died intraoperatively as well. We will talk about a very nice case. This is a common femoral artery aneurysm. He's an addict. He's hepatitis B and C and HIV. And this man, he is 43-year-old. He did cerebral aneurysm embolization in Israel, in Isota Hospital, and 3 months before he came to us. So he had a history of catheterization, and also he's an addict, so we have 2 risk factors. And he came with this aneurysm with excoriation over the skin, which is imminent rupture. And what we did is that we clamped the external iliac artery as a proximal control, and we opened the aneurysm, and what we found is something strange. We found a wire. This is a missed wire, which is a long wire. We pulled it back, it was about 2 meters, and it has some coils at the tip, which is something strange that to leave a wire like this inside a man. So the plan in this case is to do an extra anatomical bypass because the aneurysm was infected and there is evidence of fasciitis in the groin. So we have to bypass this fasciitis, but we should not put any vein inside the infection. Of course, the patient is an addict. We searched for a vein for him. There's no vein. The veins are atrophic and fibrotic. So we put a synthetic graft in the external and the common iliac artery in the abdomen, and we pulled it back. Here is the infection, here is the abdomen, and we put a gauze like here, and then we started to search how can we reach the leg. So the best way was to put it transobturator, which is through a natural bony foramen. So this is the fasciitis after debridement, and this is the inlet or the inflow, and through the posterior muscles, and here is the landing zone. If we can see the image exactly, so this is the graft from the external iliac and through the obturator foramen, which can be palpated inside the pelvis, and near the urinary bladder and rectum, going to the posterior muscle, landing to the upper part of popliteal artery. This is not the end of the story. The patient, after 2 weeks, had, this is the graft, of course, it's in the obturator, and the graft is near the bladder, which is dangerous to hit the bladder, so it has to be done carefully, and this is the open wound. And it's present in the posterior muscles, as we can see near the pubic arch and landing to the popliteal. However, the problem in this case that we should make sure that the obturator foramen is not always, it's not all open. You only have to go through the obturator canal only. And also the obturator canal has the obturator nerve, artery, vein. So we have only a minimal amount to go through. And also we have anomalies in the obturator artery. There is something called the apparator obturator artery over there. The transobturator bypass is a rare case. The collected cases in America since, as we can see, since 88 to 2008 is 78 cases only in the United States. And reported in UK from 92 till 2001, only 12 patients. And in Egypt, they have 9 cases from 2007 to 2011. It's a nice surgery. However, what happened to our patient that he has a ruptured distal anastomosis due to infection because of the remnant infection in this area. So we had to reoperate again to salvage this young man, and we operated here. We removed the infected part, and we did graft to distal popliteal below the knee bypassed. So we have our transobturator is okay, and the graft anastomosis here and then below the knee. And luckily we managed the case. This was 1 year ago, and the wound has closed eventually, and the patient has, the groin is closed, the first surgery and the second surgery here, and the third surgery here, and there is a wound to look for the vein, and the patient is salvaged with no comorbidities. We should be careful of these cases because they have these tattoos and they are hepatic, HIV, and we should be really careful in these cases. We had another carotid aneurysm in this series. It's after a central line insertion in this renal patient. He's on dialysis, and he came with this swelling, and after an X-ray we found a gas inside his neck, indicating a gas-forming organism. Through a CT we found this carotid aneurysm with clots outside, and the air is here, the gas-forming organism, and this is the skin. The patient became toxic, and the white blood cells elevated till 33 and started to burst. Here is the pus going out. We had to operate. We found luckily that the patient has an external carotid artery aneurysm, and we ligated it, and we extracted the aneurysm and drainage of the abscess. We inserted a VAC, a negative pressure wound therapy, in the neck, which is a little bit unusual, but the patient salvaged this without any complication. We had many different femoral aneurysm, mostly traumatic. This is a case femoral aneurysm with fistula. This is a femoral artery aneurysm, looks like a cauliflower with fistula as well after trauma. We did a primary repair. This is a popliteal artery aneurysm after a trauma, which is a shrapnel after the last Gaza war. And this is the shrapnel. We removed the shrapnel We removed the shrapnel after a posterior approach technique, and we did a primary repair as well. This is a popliteal aneurysm as well in a young lady, and with a primary interposition graft. This is a very rare case of a mercury injection in trial to suicidal attack. He's a pharmacist. He knows the killing stuff. This is mercury injected in his arms with a brachial artery pseudoaneurysm. As we can see, the mercury. Chest X-ray has mercury in his chest. The ultrasonic view shows the snow-like feature of air, and the aneurysm is extracted with a ligature or a simple repair. We had a lot of post-cardiac cath pseudoaneurysm. We did primary repair in the 3 cases, rupture and infected aneurysmal fistula with central vein occlusion. We occluded them and they get well. The conservative cases, the last 2 conservative cases, a case of Behçet syndrome. It's not too big, and the patient on medical treatment, so we conserved upon this patient for 3 months. Every 3 months we did an ultrasound. This is a rare case. The lady has removed a tumor from the kidney, and when she came back after chemotherapy, she found an aneurysm inside the renal artery, inside the kidney, and we conserved upon this lady because this is a solitary artery aneurysm, and we consulted, we saw the literature, they did the same. Conclusion. The Shifa Medical Complex Vascular Department is a busy working center. We have varieties of aneurysms are dealt with, mostly complicated cases. We need to introduce EFAR into our service and endovascular service into the governmental hospital, which is something we wish to get out from the recommendation of this conference. And there's a need actually for a national screening program to detect silent elective cases of aortic aneurysm.